So welcome everybody, my name is Dr. David Pearson. I am a clinical medical physicist and the Associate Dean of Admissions and Strategic Enrollment. Those are often things that are not necessarily well understood. So for example, does anybody here know what a clinical medical physicist does or what area of a hospital a clinical, go ahead. Yes, radiation oncologists. So we either work in radiation oncology or in radiology, but people that work in radiation therapy outnumber those in radiology by about 5-1, just because the amount of physics support that is needed. But this is just an example of how, being in a hospital, you're part of a very large team, and not everybody fully understands what you do. Within my cancer center, I think I walk past about 20 people a day, and they have no idea what it is I do in the department. We all help the patients, but we all have our own niche specialties. And in the case of clinical medical physics, as you can imagine, that's a pretty niche specialty. How about admissions? I think you all have some idea about how that works, what we do in admissions. But I do want to clarify probably a few myths, because I think there is some misconceptions about how this works, how this process works. One of the misconceptions is maybe brought about because in the world of undergraduate institutions, you may have seen on the news, I've not seen it for a while, but a couple of years ago, some of the major institutions were in the news because sons and daughters were accepted into Ivy League universities because someone made like a contribution, bought a new building, put their name on a building, something like that. And so that, what the effect that has is it kind of causes controversy, because you kind of guess, well, did that son or daughter really deserve to get accepted into that institution, or was it simply because money was put forward and that kind of greased the wheels of admission? I just want to make it clear that in the world of medicine, that doesn't happen. Here at the University of Toledo, we're not under any pressure at all to accept any applicant. We're not under pressure to interview anybody because of a donation or a friend of a friend. Let's say the president of the university's next door neighbor comes over and says, hey, my kid's applying to your med school, it'd be great if they got accepted. That information doesn't make it to us. If it does make it to me, it doesn't make it to the admissions committee. Our admissions committee is the final say. So one of the things I don't do, and one of the things that my admissions deans don't do, is we don't accept people into medical school. So what do we do then? If I'm not the person accepting people into medical school, it's not me that made the decision. If it's not our associate deans and assistant deans that made the decision, then who is it? So it's our admissions committee. And we keep the admissions committee isolated, not only from external pressure or even from internal politics. We keep our admissions committee shielded. They get to vote independently. We don't have committee meetings in a large room where people discuss applicants. Instead, your decision to be accepted here was made essentially as a homework assignment. We sent your application to our admissions committee, and they voted using an online portal, the same portal that you use to apply here. Our admissions committee went in and they reviewed your application and they voted. They didn't talk about that with anybody else. They didn't meet with anybody. They didn't get together and have a discussion about the pros and cons of any one applicant. Every decision they made was independent, their own thoughts, their own opinions. And we do this intentionally. And we're one of the few medical schools in the country that does it this way. In most medical schools, the admissions committee functions by having a big meeting and getting everybody together and then discussing applicants. That's not a great way of doing it, because what happens is the person with the strongest voice and the strongest opinion, who may be a surgeon, not saying that they are, but they probably are, will have a strong opinion about that applicant, and they may vouch for that applicant, or they may say a negative comment about an applicant just based on one thing. And then the entire admissions committee's opinion of that applicant may be then swayed by that one voice. So we especially don't do it that way. What that means is I am extremely confident that we have not made any mistakes. I am extremely confident that everybody that's here today is here using the best methodologies of accepting students into medical school. Our interviews are more robust than most medical schools. Our decision making is more robust. It means that we have a lot of faith, and the faculty at the institution also have a lot of faith that our decisions are being made without political pressure. And that puts the faith in the system, which means that we can all be confident that everyone here today is qualified. Now, moving on to my kind of welcome remarks. When I agreed to take on the responsibility of standing here today and talking to you about and welcoming you, I decided to get some advice from someone I looked up to as what to talk about, what should I say to you guys. And so I went to someone I trust and someone I look up to. That person is Dr. Cooper. Dr. Cooper was the Dean of the College of Medicine for 10 years and only just stepped down. And if you know anything about deans of medical school, that's a very long time. Spending 10 years in that position, that would be like being the president of the US for 10 years. You can, it takes a lot out of people. And so he recently stepped down, but after he stepped down, I went to him and said, I'm going to be giving this presentation today. Can you give me some advice? What should I talk about? And his advice to me was, David, speak from the heart. And I thought, well, that's not really the advice I was looking for, Dr. Cooper. I was kind of thinking more along the lines of a PowerPoint presentation, or maybe some bullet points, or maybe, you know, we arrange a session where you can give me some guidance on how to give a great presentation. But speak from the heart was all I got. So I went and did what probably everybody else would do in this situation. I went to do some research on public speaking and found some resources. So anyone here, if you were asked to give a presentation to a large public audience, where would you get advice? Where is there like free advice available, free guidance, free examples of public speaking? What's a good resource to go to? Go ahead. YouTube, yeah, all right. What specifically on YouTube? Yeah. TED Talks, yes. Yes, so I watched lots and lots of TED Talks. And there was one thing I picked up that a lot of the TED Talks have in common, and that's to tell a story. So I'm going to briefly tell you a quick story that I hope you enjoy and I hope you get something out of. So the story is about, and this is very relevant for me, the story is about a cancer surgeon. Our cancer surgeon is a prostate cancer surgeon. So we'll call him Dr. Singh. Dr. Singh specializes in removing the prostates from men with prostate cancer. Now, prostate cancer is one of the most common cancers in the US, in the world, in fact. And it's so common that we have a common idiom that many men will die with prostate cancer, but not from prostate cancer. It is that prevalent. So it's a very common cancer, and so as you would imagine, Dr. Singh is very busy. He spends a lot of his time taking out prostates. But it turns out that not everybody that he talks to needed to have their prostate removed. So prostate cancer is actually a very slow-growing cancer, and in many cases, there's a few good things for us as a species that really helps us survive prostate cancer. One is that the prostate is actually like a box, and the prostate cells can't really easily escape. They're locked inside this box. So the prostate is a capsule, and the prostate, when there is cancer inside that box, it's very difficult to get out, which means it can't really spread very easily. And so it can grow within the prostate, but it's much less likely to metastasize to other areas of the body. So if it's caught early enough, we can be pretty sure that as long as we see no evidence that that box has been tampered with, then we can see that the prostate cancer hasn't got out. And so we can be more conservative with our therapy, which means if we know the cancer hasn't escaped the prostate, then we don't need to do chemotherapy or people poison, as we call it in radiation therapy. So we can do more conservative therapies. Another thing that we have going for us with prostate cancer is that it's one of the few cancers where you can do a simple blood test to find out whether people have it. Have anyone heard of this test? Yeah, what's this test called? PSA. PSA test, yes. And what does PSA stand for? Prostate-specific antigen, right. So we have this test, the PSA test, prostate-specific antigen test, and we can just do a simple blood test on men and find out how likely it is that they have prostate cancer and how likely it is that prostate cancer is advanced. And then, of course, the next thing we would do is we would do a biopsy. So we can take a quick sample of cells from the prostate and we can look at them under a microscope. And if those prostate cells look a little bit ugly, then we know that the prostate cancer is not very aggressive. And if those cells look very ugly, very unlike normal cells, then we know it's a more aggressive type of prostate cancer. Does anyone know what that test is called? Looking at cells under a microscope specifically for prostate cancer and giving them a score based on how ugly they are. Yep. Gleason, yes, the Gleason test, the Gleason score or Gleason grade. So by doing a biopsy, we can check to see how aggressive the prostate cancer is. Okay, so this is important because it helps to explain one of Dr. Singh's problems. So Dr. Singh would have many men come to him and he would look at their PSA and he would look at their Gleason scores and he would identify that they're very low risk. The prostate cells look a little bit cancerous, but not very aggressive. It's going to be very slow growing. Their PSA is not particularly high, just a little bit abnormal. And for those men, the standard of care is to do nothing. Because the cancer is growing so slowly, there is, in many cases, a good chance that the cancer will grow and the patient will actually maybe die of natural causes before the cancer escapes the prostate or causes any negative effects. And so for those men, the philosophy is to do something called watchful waiting. Watchful waiting just means observe the prostate cancer, do the blood test. If the blood test shows an increase in PSA, then maybe do an MRI, maybe do a biopsy, but only in the situation where we can see that the prostate cancer is getting worse, then we consider the surgery. So for a lot of Dr. Singh's patients, he would meet with them and he would tell them, good news, we don't need to do a surgery. You don't need to have a cancer surgery. And that really is good news because the cancer surgery, although relatively straightforward by surgical procedures, still has risk. People die under anesthesia for nothing to do with the surgery itself sometimes. But also there's some negative side effects from the surgery. People can have complications. The prostate is actually all the way around the urethra. And so to remove it without damaging the urethra can be quite tricky. And any damage to the urethra could mean that the male patient has to be catheterized, which means they'll be peeing into a bag because their urethra isn't working. Or there's nerves that control sexual function and bladder function. And if those nerves are damaged, the patient may lose bladder function or sexual function. And so this surgery doesn't go without risk. So Dr. Singh would tell the patients, you don't need surgery. That would be it. He would say, great news for you, no surgery, everything's fine. The next day, these patients would come back and they would see Dr. Singh again and they would say, I want this cancer out of me. I want you to remove my prostate right now as fast as possible. I don't care. I just want to get this cancer out of me. And Dr. Singh couldn't understand it. He was giving them the best medical advice. He was telling them good news. They weren't going to die under anesthesia. They weren't going to have all these complications. but many, many times patients would not follow his advice and go straight for the surgery. And Dr. Singh realized that the problem was with him. He realized that the problem was his communication. And so he needed to improve his communication with his patients, primarily because he knew that the advice he was giving was sound and he wanted his patients to follow his advice. Now, being in an academic institution has lots of benefits. One of them is that we're surrounded by experts in many, many fields. So Dr. Singh went to talk to someone who he was recommended, who was an expert in communication. It turns out this person was actually in the business school. I guess people in business must have to be really good at communicating. And so he talked to someone, a professor of business, who told him about what we've learned in the last few years about communication. And what we've learned is that there are essentially 3 types of conversation. And if we're having a conversation and we're not in the same type of conversation, then we're not listening to each other. We're not truly communicating. And the 3 types of conversation are social, so kind of small talk, practical conversations like teaching, and emotional conversations, which as you can imagine what an emotional conversation is. And you may have come across an example of this. You may have come home from work one day and you've been very upset. You've told your significant other, your roommate, whatever, oh, I had a terrible day. My boss is a jerk. They don't appreciate me. I do all this work and they don't realize it. And you're angry about how bad your day was. And your roommate or your significant other, your loved one, your sibling says something to you like, have you tried doing this? Have you tried talking to them about it? Have you tried taking them out for lunch? And you get even more mad because you're expecting them to say, oh yeah, your boss is definitely a jerk. Yeah, they should definitely listen to you more. They should appreciate you more. That's what you were hoping for. You were hoping for someone to empathize with you. You were hoping for someone to agree with you, not to give you advice. That's exactly what was happening with Dr. Singh. Dr. Singh's patients had just been told they had cancer. And so they were understandably emotional. And when Dr. Singh spoke to them, he didn't ask any questions. He just went straight in with the medical advice. He told them, this is the plan. This is what we need to do. And what we need to do is watchful waiting. And they weren't listening. They weren't listening because they weren't having the same conversation. The patients were expecting an emotional conversation. What they really needed was a hug, or maybe the verbal equivalent of a hug. But what they were getting was practical advice. So once Dr. Singh learned this, he changed his approach. The next time a male patient came in who was low-stage prostate cancer, less aggressive, the first thing he said to them was, how does this cancer diagnosis make you feel? And the patient opened up and the patient told him, I'm worried about my family, thinking that they're going to have to look after me and the burden I'm going to cause. I'm worried about how the people at work are going to treat me differently. They're going to look at me differently. They're going to think I've got one foot in the grave. They're not going to want to talk to me anymore, but they're going to treat me differently. And then Dr. Singh empathized with the patient and told him how his father had got sick and how it brought the family together. And they had this conversation, this emotional conversation, this deep conversation for just 7 minutes. Just 7 minutes talking with the patient and empathizing with the patient. And then after those 7 minutes, Dr. Singh said, is it okay if we talk about some options, some medical options? And they both went into a practical conversation together. And the patient opted to follow Dr. Singh's advice and not get the surgery. And now that Dr. Singh has learned this basics of communication, he is able to convince almost all of his patients. He's universally able to get them to follow his medical advice. So what is the point of me telling you this, right? What is the take-home message? Well, if you're a medical student here today and who wants to be a surgeon, then you've just learned everything you need to know about how to convince your patients, right? If you're here with a budding surgeon, with a budding physician, then hopefully you've learned not to give practical advice when someone comes home and says that they're mad at their boss or they're mad at how their day went. But hopefully everybody gets something a little bit out of this. So I just want to thank you all for coming here today. I'm going to be around here all day to answer any questions that you might have, whether that be about prostate cancer or radiation therapy physics or admissions to medical school. But we really do appreciate everyone that came here today, and I hope you enjoy the rest of your day. Thank you.